check, mic check, mic check, mic check, live stream check, mic check. Mic 2. Mic 2, 2.
Oh, lordy me, it's going quiet. It's like the start term being up here. Okay, morning everyone. Oh dear. Well, that's not a great start to the morning, so, and I think we've had coffee. Morning everyone. Yes, that's great. That's much better. I think that first poor start was because I've said good morning to a lot of you already, so I'll forgive you for that. Can I say thank you? Thank you for taking the time to come. The reason we do it is because you want us to do it, and that, you know, speaks volumes, absolute volumes, because this isn't the board, the senior executive asking you to come. It's because you've asked for these sessions to happen, which is brilliant, and we get a huge amount of value out of it. So I really sincerely hope that you all feel you get real value out of today as well. So we have to say to ourselves why we're here. Get the clicker in the right way. And I was thinking on the drive in this morning, what do I say to people as to why are you here? You've taken out time in your day jobs, which is great. Some people obviously are scheduled to work, so on a shift, so can't make it. But you have to get value out of the time that we've got together. So when you think about why we're here, let's take it as an opportunity to kind of reflect, plan, but more importantly, to generate those new ideas. And that is hugely important because as an organisation, we've never stood still. We've always wanted to come up with the next thing. And reputationally, believe me, and this is us, reputationally, we are right at the pinnacle. Everything you do gets noticed. Everything we talk about, even the smallest things, actually filter through. Just had a conversation with Phil about reputation and where we're being asked to go globally as LTHT that 10, 12 years ago would never have happened. And that's all thanks to you and about the planning of where we go next. Because we can't stand still, that's absolutely for sure. We know, as everybody knows, we are in an extremely challenging time. We know what it feels like at the CSU level, believe me. We're all close to you. And if you don't think we know enough, make sure you make those notes and let us know. There's a Q&A at the end of this session. And really say what we can do to help you come up with the ideas and the forward planning that you're hopefully going to be doing this morning. But we need to know. It is an incredibly challenging time. I've been in the NHS, as you all know, for a long time. A lot of you in this room have. This is probably one of the most challenging that I've witnessed. But we have to ask ourselves, why is that happening? Let's just think about those challenges for a moment, a little bit sobering, unfortunately. And we hear so much, don't we, in the media? Everything you listen to, everything you pick up, everything you read, it's in your face. This should have worked. Clicker's not working. Gareth. Don't tell me the battery's gone down. IT supporter on it, Gareth. There we go. There we go. This is what we're hearing all the time. All the time. Look at it. I'm not quite sure whether it's 22 billion. Next. Clicker's not working. There we go. Give you a few minutes to read. This is what's going on around us all the time. This is the climate that we're living in. And it's not particularly helpful for any particular sector, whether you're in private sector or public sector or anything within certainly I thought she was bringing you a clicker, anything within the public sector, any of the divisions. So I need to keep moving these slides so that, unfortunately, I've not got control of it at the minute. No, we've got a problem with the clicker. I will say next slide. These are very, very tough financial times. We've got a massive, as we've heard, national debt, national deficit. Can we click? And depending on the headline, we jump from that 22 billion to that 40 billion that we saw. And I'm only getting my head around the differential between, what's the difference between those two 20 billion? It's quite big. And I'm just beginning to understand it. And Rachel Reeve has been amazing, actually. I have to say she's a Leeds MP, so obviously we know her as a team. We're close to her. Fingers crossed, that'll work to our advantage. But this is a big deficit that we sit in the middle of as a health organisation. Whilst inflation, so let's go back a stage first. So all the signals are out there, aren't there, on the pressure. How are people feeling in that? And is it likely to let up? So we're optimistic, aren't we, about, optimistic. We're keeping our fingers crossed and hopeful that the announcement she makes next week might be helpful to our sector, and particularly helpful to our THT. Whilst inflation interest rates have come down, you saw that at the height we saw in the last few years, it has to stay at that 2%. There was a big debate, I don't know whether anybody heard it this morning on BBC, about holding interest rates, inflation, at 2%. Cost of living, look at it. We all feel it. It's still very, very real to all of us, whether you're a patient, whether we're a member of staff, whoever you are, wherever you sit in the country, it's there. That cost of living is there. Energy costs, can we have the next slide, please? I think, well, hold it there. No, go back. Sorry about this, everybody. There we go. The energy costs, they're set to rise, and we've got this huge headline, of course, no universal government support for the energy bills this year, reductions in who's eligible, winter fuel allowance, that's made a huge headline, particularly for the elderly, and of course we have an awful lot of elderly people come through our doors for various reasons. These are all very impactful on those, especially in the deprived areas. And of course we have an awful lot of that to contend with in health inequalities that we're going to hear about later on the agenda. They are big users of our NHS services. So everything we hear, we read, we pick up, affects us, whether as an individual or whether at LTHT or the services, clearly, that we provide. So, where does that put the NHS? I'm here to say, this is how we sit within the big picture. So what are our solutions going to be? Here we go, we're off. In March this year, flat spending announcement for the NHS for 24-25, and the extra 2.4 billion, well, we'll come back to that. That's going to be soaked up, and I'll show you why in a minute. But the backdrop for where that extra money went, it was the industrial action that had cost the NHS 3 billion. So in other words, we're flatlining. That there is no more money in the NHS, there is no promise of any more money in the NHS, and if you think about the inflation, cost of living, everything else, we're probably worse off than we were. And we're all feeling that at the Waste Reduction Conference, which we had not too long ago in here. We all felt that again as to where can we help LTHT, our own service, but more importantly, the people that we serve, how can we continue to deliver the excellent services that we do and keep our standard and our quality there at the same time as having, at best, a flat line, at worst, a reduction in the amount of money that's coming into the NHS. So, the suggestion is there won't be any more serious money into the NHS without reform. That's a very, very, very clear message that's coming out of the centre. And I want to tell you how close we all are, Phil, me, some of the senior executives. We don't just sit in Leeds. In fact, it would be rather nice if I could sit in Leeds for a little bit longer, but we'll come back to that one. We are actually trying to get very close, so whatever decisions are made nationally, Leeds comes into the focus as the first thought, as to they are doing X, they are doing Y, and you are, and we've got a great future ahead of us, but we need that investment into us. And the investment comes because they believe we will deliver. And we always have, but today is about how are we going to deliver in this tough climate. One of the messages that is really irritating me is this one, that we're bust, that we're broken. I find it so degrading. You notice they've stopped saying it, and I have made very serious comment back that this is not helpful. This is absolutely not helpful. Has it lacked investment over a long time? Yes, it has. Absolutely, unquestionably. In the two areas where we could get better productivity, which of course is in capital investment and IT&D, all part of the same part. And you know that, I know that, we all know that. And we are putting up, and we've tolerated it for far too long, but this is not the right answer to the hard-working people within the NHS that you know, broken. We need a message of hope. I'm going to get rid of it because I can't stand that one. Here we go. Without reform. We've got an optimistic consultation starts on Monday. For those who missed it, the 10-year plan, I'm going to be talking about that as a board over the next couple of days. It's open until the 2nd of December. Can I encourage you to go online and find it and make all your comments back? They are listening, and then what we can do at the top of the shop is to then encourage people to say, when they've got all these comments back from the general public, which we are, and particularly those within the service, who I would, with respect, suggest that probably know more than they do, that they need to listen to what do we want in the 10-year plan. The 10-year plan is not going to solve the problem. I think we could all probably, if we had 24 hours together in here, we could probably write that 10-year plan in 24 hours. However, having said that, what sits behind the 10-year plan as to how we can deliver is really, really important. And what reform are they prepared to support for us to make our jobs of delivery of our services to the people better, more efficient, to go back to their words, and more productive. Okay. It starts on Monday, 2nd of December. Okay. Apparently it's a very broad consultation, and we do need an organisational response, but as I said, encourage your staff, encourage everybody, patients, anybody that you're talking to respond to it. Change and reform. Oh, golly, here we go again. We do need it. We're on a 1948 template, aren't we? That's been kind of added to, bodged to, buildings the same, you know, instead of proper builds, we've added on, we've cemented over various things that get onto the rack issue. So we're not in a great place, and we do need that reform. We have done it here at LTHT, And we've done it because we've had the right culture to do it in the right way. And this goes back to that broken glass comment. That is not the way to take people along with you, to say, let's do the reform and change together. We need it. You have to do it because actually, believe this or not, people do the reform and change. Pieces of paper and constitutional documents do not do change. People do it. But we've got the right culture to be able to say, right, okay, we've been through that cultural change. We're great, actually. Absolutely fantastic we are as an organisation, as the one culture, as the one team, LTH team, Team Leeds. So we can do this, but we can do it with the hope of this is going to be better when we've done it. But they are going to have to trust us and invest in us for us to be able to do that. I'm not going to say very much more because I think the rest of the day, the morning, we've got 2 days actually, is about you. And this comes back to, if we want reform and change, all the work that hopefully you're thinking about within your CSUs at the moment, then it is down to you. We have enormous hope, and the sector has. People believe in us. They rely on us. So we have actually got to do the best, not just for us, that's common sense, but for people. And how we do it is as important as doing it. Making the change that's sensible, that people will respect, and that we can then own as, even if it isn't how they perhaps see it, that doesn't matter, because we can persuade that Leeds knows what they're doing. Leave us alone and we'll get on with it, but trust us to do it. So I want you to really enjoy this morning. I'm the heavy part of the morning, by the way. I'm the kind of gloom and doom, but giving the optimism. So we're going to be around. I just want to say that the Community Trust Chair and CEO are joining us at the coffee break, so they're coming in at the end of that. Because a lot of what we need to think about is the partnerships and how we do it. But Phil is going to talk very much more about that kind of area of how, rather than me. Thank you for listening. Sorry it was a bit heavy, but the thing is, it's contextual, that's all. Okay, enjoy your day.
Thank you very much, Linda. Good to see everybody here. Thanks for finding the time, and appreciate those colleagues who are delivering services, but I know it's great to see a range of people here, and I think we'll have a good discussion. Slightly disappointed this is working, because I've always wanted to say next slide, please, but let's just go back to where I wanted to start. Okay, so Linda's given a good outline of where we are, and I'm just going to rattle through this bit before we get on to what we really want to spend our time talking about. The 10-year plan, as Linda's referenced, spells out a direction of travel for the NHS that realistically we know has been talked about for quite a long time. There's nothing particularly new in those 3 priorities, the 3 shifts, and I think we'd all concur with how, with that direction of travel. And I think actually a lot of what we are doing in LTHT already helps us think about that direction of travel. But there are some areas that we want to explore with you this morning that I think we need to double down our focus on to help think about how we'll contribute to that. The Darcy report, big report, actually a good report, although again, much of it not new, much of it's information that we knew about 20 years ago. Lots of things about what's wrong with the NHS, and we all could, again, as Linda said, have written those down. But I also want to focus on some of the really important things that Darcy drew out, which have got slightly lost in the current noise. But actually, these are all quotes, these are all points that he made very clearly, that most people, and we all know this day in, day out, most people get fantastic high-quality care from the NHS. And actually, patient safety improvements compared to when we were 20, 30 years ago are incredible in the way patients do come to harm. We know patients come to harm, but actually we do keep our patients safe, and we have much better focus on our patient safety and quality of care than we used to. We've got progress in long-term conditions like diabetes, and there's some really great work nationally going on around that. And above all, and Darcy specifically makes this point, that actually our clinicians, our managers, everyone who works in the NHS is hugely committed, and actually we have some of the best managers and clinicians in the world working in the NHS. So it is important that we hang on to the positives, because as Linda alluded to, there are lots of examples of good practice. Where the NHS is not great is actually spreading that good practice around the whole of the NHS. So we have a paradox of having a national health service that often doesn't function nationally. Here's some headlines that we've read. What's interesting is that all of these headlines date from before 2018. So one of the things to remind ourselves is that the NHS can always hit breaking point in the next few years, warns Doctors Group. It sounds quite familiar, that actually, doesn't it? But actually that, as you see at the top, this article is more than 13 years old. We know about the budgets, the finances, the challenges, but what is really important is that the NHS has always rallied itself. The NHS has always thought, how can we respond to the crisis that we find ourselves in? And we know what the external drivers of that crisis are, but we also know that in this organisation, we're very focused and have a strong track record of how we can get ourselves out of a position. We're not in crisis now, but we are working really hard and collectively to ensure we keep ourselves in the right place. And I'm going to just go through some of the things that we've achieved. And we're in a very different time than those who were in Leeds teaching hospitals a decade ago. But actually, it's worth just reminding ourselves of the position we were in 10 years ago, 11 years ago, and what we've done to turn around. So I'm not going to go through these in huge detail, but we've improved our finances, we've put strong clinical leadership in and improved our position in terms of our regulatory function. We've built a new pathology block. Our capital investment has really strengthened. Our Leeds improvement method has been something that's really helping us. We've got a long way to go with it, but really helping us drive our improvements forward. And of course, we are very optimistic, as Linda said, about our ability to build our new hospital. We've also worked really hard on our staff engagement, and this just again is a reminder of that time between 2012 and 2017, and we've held ourselves in a really good position from being a really poor place to work to actually one of the best places to work in the NHS when you look at the staff survey. And there's still more work to do, of course there's more work to do. But all of these messages really are to say that actually we can maintain and improve from where we are. And that's going to lead me in a moment to what we now want to focus on, which are our annual commitments. I just want to pause because those of us who were at the exec management group yesterday heard a really powerful reminder of why we're actually all here. So I asked Claire, our Chief Operating Officer, who assures me she can do this without a microphone, because I just want Claire to share something that she'd been sent, which I think is really powerful for us all to listen to. And I know that some of the people involved are in the room, and I've already warned them the lights are dim, so we'll spare your blushes. but it's just a really powerful reminder of what gets us all out of bed in the morning and come to work. Thank you, Claire.
We had a terrible case last week of a 13-year-old who had a spontaneous cardiac arrest outside hospital and who ended up in the ICU. The clinical team were aware this young boy wasn't going to make it. His stepdad was an inpatient at St James's at the time, having had a significant oncology surgery. On learning of the situation, Bridget Sutton, Lee Parker, Brooke Ward, along with the wider clinical team, moved heaven and earth so that Dad could be transferred across site. This was incredibly complicated, but they made it happen, and this young boy passed away holding his left hand.
So thank you, Claire. I mean, I think if you're not a bit choked up by that story, then you're a braver man than I. Just tells us what we do every day, what our staff do every day, where we go the extra mile for the people that we serve. And whatever we have to talk about, whatever the big context of the NHS, let's just remember that those small acts of kindness for the people that we serve are actually what we're all here to do. And I know you all believe that, and we really must hold on to it, despite all the negative press, despite all the challenges around money, performance, whatever else it might be. So thank you for that. Okay, so I'm going to go on now, because I'm going to just rattle through these, and then we can get into our table discussions, because I think that's where the benefit of getting us all together is. Just to remind ourselves, we've had our second year now of annual commitments, and we're halfway through the year. We've met with all of our clinical service unit teams to go through the progress. And I think I can honestly say as an executive team, we were really inspired and had a lot of confidence in our leadership, the way that everybody's going about tackling that. So again, let's hold on to what we're doing really well in Leeds teaching hospitals. And there have been some real successes, which I'm just going to pick some headlines out. We've had our fantastic sustainability commitment, in part driven by staff feedback saying this is something we want to focus on. We'll send these slides round, so you don't need to kind of know these figures, but we're making huge progress across the range of thinking about how we contribute to our decarbonisation agenda. Our research and innovation work continues to grow apace. Leeds is really now getting a national and international stage for its research and innovation efforts, and that's due to the team in R&I, but also to everybody else getting involved in this. So we're really growing our participation and our funding in R&I, and thinking about how we can do that to provide better patient care for our communities. We've made huge progress in our healthcare associated infections. We've still got some challenges to go. You can see the sad face at the bottom of the slide. But, you know, we've made great progress. We've won awards for the approach we're taking with IPC. We've had teams coming to see what we are doing by working together to try to make great progress to reduce harm for our patients. We're spending a lot of time on the financial challenge. I don't make any apologies for that. It's a tough time, and we've got to maintain control of our own destiny, and we're working really hard. Again, I said to our clinical directors yesterday, thanks to what you're all doing, we're still in the position of having that control over what's going on. And that's in stark contrast to a lot of the systems so far. So we're really on it. We're working really hard. We've got a long way to go. But we're still confident that we can land the year where we need to keep control of what we're doing. We've had some wonderful work around staff retention. You can see our voluntary turnover and turnover targets have really got traction now. It's become something we're really thinking about, looking after our workforce, understanding why people might want to leave, thinking about what will help them stay. Really important. As Linda said, healthcare fundamentally, it's a people business. Whatever technology might bring, it's all about the people delivering that compassionate care, that wonderful story that we just heard about from Claire. So our staff survey is live. Just a plug for that, please encourage people to fill it in. The more people fill it in, the more informative it is for us as an organisation, and the more we can understand what people are telling us. We've made great strides, sometimes difficult to remember again where this organisation was in terms of its digital systems several years ago, and fantastic strides that the teams are making in conjunction with all of you. So, you know, great progress in terms of our digital system utilisation. Are we there yet in terms of using them to their full potential? No, we're not, but we know we can set ourselves up for further successes. Some of these numbers are fantastic in terms of our progress, reducing how long our patients are waiting for our services. You can see some of the progress we've made between last year and this, despite all the pressures, and particularly perhaps highlight that one at the bottom, people waiting over a year for treatments, reduced from over 1,000 down to less than 400. So really fantastic progress against all those other pressures and headwinds we've talked about. And again, that's the detail, that's the work you're all doing at the front line with individual patients thinking about what's best for them. So really important that our teams know the benefit they're bringing to the whole organisation and the people we serve. Okay, so that's all I want to say. We're going to move into our table discussion now. What we've asked you to do, spend 20 minutes, I think we're all right for time, 20 minutes, how things have gone, the key successes for your CSU, what are the key areas you need to get those 7 commitments over the line in the next 6 months. We'll need to start thinking about next year's commitments. So the key thing here, as we know this year, is not to just throw all these away and start with a new 7, but we do need to think, how do we keep this going? How do we keep the momentum going? How do we keep the priorities that are there for all of you? We are going to use Slido, so the QR code is there, and I think possibly on tables, I'm not sure, but we'll make sure you can do that. So rather than collating written feedback, we're going to get people to fill that in. At the end of the session, we'll take a little bit of feedback. We're not going to do death by 25 table feedback, but we'll have a bit of a coming together. But the key thing is really getting down in your teams to thinking about how you're going to help the organisation and help what your services are to get us over the line with those. So thank you very much. Thanks for coming, and enjoy the rest of the morning. I just interrupt to say, can you, in the next 5 minutes, just try and kind of wrap things up, and please use the Slido function, and then we'll just have 5 minutes for any burning points people want to raise before we move on to our next session. Thank you. Okay, folks, can I bring us back together just for a few minutes? Thank you very much. There's clearly lots of great conversation going on. I hope the Slido system has worked for people. We'll soon find out, I guess, but nobody's come up to anyone and said there's nothing happening when I go on it. So I'm hoping that you've been able to capture some of the thoughts you've had. So we're just going to have a few minutes. As I say, we're not going to go around every table, but has anybody got any really kind of burning things that they want to share with the group from that conversation? Must be somebody with some burning opinion. I know there is. Oh, perfect. Thank you, Chris.
Thanks. I'm not sure this is terribly insightful, but to contribute. So we started off celebrating positive achievements, which we're very, very proud of our work around staff retention and the working environment. We moved on to our biggest area of concern, which I think should be everyone's biggest area of concern for a healthcare delivery organisation, which is reducing waits for patients, improving access. We focused on the areas of particular concern and how the different commitments interrelate to each other. Investment in the IT to help with robotic processes for data generation, and the planned investment in primary care addressing referral demand. So we feel one of the reasons that we're not seeing growth in productivity is we're spending 30% more time dealing with our growth in referral, which isn't translating into increased diagnosis, or sort of changing referral patterns in primary care. We're hoping that the investment in primary care coming onto the integrated working that we'll come onto later in the morning will help solve some of our own problems.
Great, thanks Chris. Really great insight, and I think a theme I'm sure is echoed across all the tables, and I think that partnership piece that you've very nicely kind of flagged for us later in the morning, exactly right. We've got to think how we're going to work with and support the rest of the system to actually help ourselves here in the trust. Thanks, Chris. Anyone else got any thoughts they want to share? I'll start picking on people in a minute. Andy.
Thank you. Morning, everybody. Andy Aldridge, Clinical Director for MMPS. A really great conversation we had, probably similar to most CSUs, reflecting on what's been really successful, and then thinking about where do we go forward. The big topic of conversation was actually all around people and workforce. So a lot of reflection on what we've done in MMPS around staff engagement, freedom to speak up, mental health champions, what we call our Caring for Our People agenda. And we talked about success in employing a clinical psychologist who's made a huge difference across our CSU in a whole range of different aspects of leadership development, looking after our staff, crisis management, staff resilience, all those types of things. So a real focus on workforce, and then thinking about going forward, two things which kind of came out. I think one again was workforce, about deployment and how we deploy our staff, be they pharmacists, pharmacy technicians, support workers, to support I guess what Chris has just talked about in terms of how we deliver our kind of care across the organisation. So that's something we want to give quite a bit of thought to, and how we internally make sure that we're processing EDANs and supply for medicines, all those types of things, linking back to the work which is going on at the moment. And then quite a bit about technology and rapid process improvement, kind of automation, and I think there's some real opportunities there across the organisation. So that was the summary from our day. Thank you.
Thanks, Andy. And I think I might have to move further away. Yeah, I mean, I think those themes around the fact that technology is there to enable the quality of care that we can deliver, and I think that message around getting our processes right, which actually brings its own reward for our staff as well, doesn't it? Because actually they work in an environment that works to allow them to deliver the care they want to deliver. So thank you for that. Maybe one more. Has anyone one more point? Anybody want to volunteer? Jess, thank you.
Hi, Jess Hayden, CD for AMS. We were talking quite a lot about our amazing teams who do an enormous amount of work for the improving access to timely care, and also our teams that work on the cancer pathways as well, because not all CSUs deliver cancer services, and we have quite a huge burden of cancer work that we have to deliver for our patients. So there's a huge amount of work going on in the background that perhaps is not necessarily appreciated when you look at graphs, but we do really appreciate the work they're doing. So the other conversation we had, which again is another unrecognised or less recognised thing, is the amount of work on research and innovation that's done by medical and nursing staff. So a lot of work is done outside. It's not job planned activity. A lot of work is collaborative. Trying to get research going requires a huge amount of time, and people don't have a lot of time when they have the conflicting, the requirements to deliver on clinical work and that pressure as well. So everyone who comes to LGH, a lot of people have a desire to be involved in research and to collaborate, but the demands of clinical work are very high, and so people have to factor that in. But recognising the importance of it in the 7 commitments is the first step. But there's a huge amount of work going on in this area, and we need to sort of celebrate and recognise that perhaps a bit more.
Thanks, Jez, for that. And I know that you're absolutely right, the fantastic work, particularly in AMS, but of course across radiology, pathology, lots of other parts of the organisations that are contributing to improving our cancer care, and but important we celebrate the progress and hard work that's happening. And I think the R&I point, absolutely, I think putting it front and centre for what we do and recognising that research and innovation delivers better care is something that's really important to try to kind of encourage our staff and actually our patients. And it brings us quite nicely on, I think, to the next presentation and topic, because in the research and innovation space, we know that doesn't always reach all of the patients who potentially could benefit from participation, and that's because one of the big challenges of the country and certainly West Yorkshire is around health equity and the challenge around health inequalities. We know what our societal inequalities are in this part of the country and the challenge that brings us for healthcare delivery. So I'm really pleased that Dr. Anna Ray, who's public health consultant working with us, with the Community Trust and the GP Confederation, is going to give us a presentation around where we are, what the thinking we can do around this big challenge for us, and then we've got another opportunity for a table discussion. So thank you, Anna.
Thanks very much, Phil. Nice to meet you all. I think I've probably met a few of you in the room, but apologies, I only started at the Trust in January, and as Phil said, I also work across the community and the Mental Health Trust as well, so still making my way around and meeting people. So hi if it's the first time I've met you today. So I just wanted to make sure we're all on the same page to have this discussion about health inequalities before we start. So just to kind of emphasise, people have differences in health, we know that, but some of those differences are kind of systematic, they're unfair, and importantly, they're absolutely avoidable. So these differences in health are what we call kind of health inequalities. Now, it's important to have a bit of a think about who are we actually talking about here. I think the conversation sometimes gets a little bit confusing. This, I don't know how well you can see this kind of Venn diagram, but I think it's helpful to kind of remember there's a variety of different groups that we're talking about that kind of sits under this umbrella of kind of the work that we would like to do on inequality. So you have the protected characteristics, which kind of fall under that kind of legal equity duty under the Equalities Act. But we also have groups that are experiencing kind of deprivation, so deprived communities, socio-economic deprivation, a really important group as well. We've got geography and the inequalities that can arise from differences in geography, potentially kind of urban and rural, or potentially in the LTHT example, we serve quite a diverse geography. Is care different for people who are living in Bradford and coming in to those people who kind of are based in Leeds, for example? And then we've got this other group, which are called vulnerable groups in society. Some people would call that kind of inclusion health groups. These are people who are facing kind of multiple layers of disadvantage. Maybe they are people kind of experiencing homelessness, who have had extremely kind of traumatic experiences, etc. So all of those groups are kind of falling under what we would call kind of, the inequalities between who. We're trying to think about those groups there. So this is just a graph, but it really does get to the absolute crux of health inequalities. What is it that we actually care about and that we're worried about? Now, on the bottom of this graph, you've got people living in kind of the most affluent areas. And on the top, you've got people who are in the most deprived areas. Now, the kind of length of the bar shows how long people are living for. So we can see people in the most affluent communities are living for significantly longer. This is an England example, by the way. The numbers will be slightly different for Leeds. But, people are living for significantly longer. But the orange bit of the graph is also one bit that we really care about and actually is driving a lot of the cost within the NHS and driving kind of a lot of the poor quality of life. And that's the fact that people aren't just dying earlier in deprived communities. They're living for significantly longer in poorer health, okay? In Leeds, that difference between the most deprived and least deprived is 18 years. They're living 18 years longer in poorer health in the most deprived communities. And that poorer health is starting significantly before retirement age. So people are kind of being told, go to work, go back to work, return to work, etc. But they're living in significantly, in poor health for, kind of 14, 15 years before they're even hitting retirement age. And these are the things that, we really care about addressing. So just some examples about how the inequalities actually kind of show up in the NHS. We know, for example, things like infant mortality are twice as high for kind of black infants compared to white infants. Same goes for kind of the maternal picture there. People living in deprived parts of England are twice as likely to wait over a year for elective care than people living in the most affluent areas. So these inequalities are kind of showing up in our waiting lists and things as well, okay? So these inequalities are really prevalent in our day-to-day work in the NHS. I just want to really kind of make this point quite strongly. I think equity is core business of the NHS. I think for a while we have been starting to talk about health inequalities more. I'm sure this conversation isn't the first time you've heard health inequalities been brought up, and I'm sure you've had conversations within your CSUs, within your departments about inequality. But what I really want to drive home is that equity is actually core business for the NHS. It's not a side thing. It's not an extra, let's do this if we have time, if we have a little bit of extra resource. It's core business. It should be as core business as safety, as quality, as finance. So I just want to kind of just highlight a few bits within the NHS Constitution, if I could actually read it back there. My eyesight's potentially not good enough. So the NHS provides a comprehensive service that's available to all. And it says within the Constitution that we need to pay particular attention to improvements in health where life expectancy is not keeping pace with the rest of the population. That's within our Constitution. And within our Constitution, it also says everybody counts. And I really like this wording. It says, we accept that some people need more help. It's simple. That's kind of what equity is. This diagram on the slide kind of shows it. Some people need more help. That's all equity is, okay? And that is absolutely fundamental to how we should be kind of doing business. I just want to highlight as well, some of these issues can often feel really big and kind of, what difference can we make and where do we even start? And I think it's really good news that we can actually contribute to closing the gap. This is a little bit of a strange graph, but basically it shows that gap in life expectancy, that kind of 10-year, maybe 11, 12, 13 sometimes, depends what data you look at, but that gap in life expectancy, this is what causes that gap. This is what people are actually dying from. And we can see here that the diseases people are actually dying from are mainly preventable, manageable disease, okay? So it's not kind of some strange, mysterious cause. You know, this gap in life expectancy is being caused by preventable, manageable disease. And the NHS has a role in playing in preventing and managing that disease that causes this gap. So just to highlight, in case some of you don't know, LTHT does have kind of a health inequalities and public health strategy. It was put in place in 2022. It tries to think about what is the role of LTHT as a kind of partner in local health systems, as a provider of clinical services, and as an anchor institution. And what difference can we make to inequalities, thinking about our role in those three ways? And these are the building blocks of our strategy. We've got kind of a data piece there. We've got patient and carer community engagement, leadership and accountability that kind of form the foundations of what we need to do to try and tackle inequality. And as we go up that pyramid, we kind of get to our enablers, embedding equity within quality improvement, person-centered care, organisational development, giving people the skills and ability to actually do something about tackling inequality. And then hopefully this will lead to kind of equitable clinical services and the delivery of preventative programmes to help narrow the gap. So I just wanted to put a few thoughts out there. I don't have very long to speak to you today, so I'm not going to go into a kind of a long kind of explanation of what exactly we should be doing and how much. But I think just putting out there some thoughts for how you might start thinking about doing something about health inequalities within the trust. So first of all, I just think it's really imperative to start somewhere. Okay, incremental change in this space is really important. There isn't a silver bullet when it comes to tackling health inequalities. Health inequalities have been around for hundreds of years and they're likely to persist for many, many more years to come. Doesn't mean we can't be making incremental change and incremental improvement. So I think that's really important to remember. There isn't a silver bullet, but together we can do these small steps that do make a big difference. And I think a really important thing to remember, especially in light of what I said, that equity needs to be core business, is that all change needs to be improvement. I think we can probably all agree with that. But all improvement narrows the gap. So it's not always about doing something new and different, but it's about the improvements that you're already making, trying to tilt those towards equity, okay? And making sure that those improvements we're making narrow the gap for everyone, okay? And they don't just have improvement for kind of affluent populations or people who find it really easy to access healthcare, for example. So a few starting points for action that I've kind of just pulled together for you to think about in these discussions coming up in a few minutes. So data is really important. It might sound mundane. It might kind of feel like, how does this really change anything? But with data, we need to make that invisible stuff visible. We need to see where there are inequalities in what we're doing, that these inequalities can be kind of systematic and really embedded in how we deliver care, how we plan care. And without looking at some kind of key variables like deprivation or ethnicity or whether someone has a learning disability, and looking at our performance indicators by those key variables, how do we even know if we're making things worse or better? Okay, so it's really important to make the invisible visible and let data kind of guide some of your decision making. Planning for the margins rather than planning for the kind of population that we know will take up services and that we know find it easy to access care and can navigate things well on their own. So the Trust has started to bring in kind of health inequalities impact assessments. You'll probably be hearing more about those over the coming months. But tools like this can really help you kind of think about, okay, we're going to make a big change in the service, we're going to make an investment, or we're going to shift resource here. How will this impact some of the communities who are at high risk of poor health outcomes? And having that kind of central to your thinking. Obviously, listening to patient and carers who have experienced inequality or experienced poor health outcomes is really important. And one kind of useful kind of thought tool that I've used over the years is to consider how can you poverty-proof your pathways. So if you have a change that you're thinking about or a particular pathway that you're finding problematic, put yourself in the position of someone who's living in poverty and just go through every single step of the journey that they need and try and think, what are the barriers that I would face, if I was living in poverty at this point? Is it to do with health literacy? Is it to do with that they're, slightly chaotic lives and unable to kind of access things in the same way? But going through that kind of step by step and trying to put yourself in the position of someone experiencing poverty can be a really helpful exercise and can generate lots of thoughts and ideas. I want to just emphasize as well, simple things make a big difference. So things like smoking, we might think, smoking, it's just a small thing, giving someone smoking advice, referring to them smoking cessation team within the hospital. These are really big things. Smoking is actually the biggest thing that we can do to tackle inequality. It's accountable for such a large amount of that difference between life expectancy from the most affluent to the most deprived, okay? So if we can just do small things like identify smokers, refer them into the Stop Smoking service, give them brief advice on smoking cessation, these things actually make a really big difference. So just to emphasize that. So embedding equity is also really important. How do we tilt those existing change programs towards equity? So I've already kind of mentioned this, so I won't go on too much. But I think it's really important within change programs that we actually have some sort of monitoring within our change programs that would highlight if the change we're making is actually making things worse for the most deprived communities in Leeds, or is it making things better? So making sure that even within our change programs, we're just keeping an eye on that bit, and we respond to that change if we see that this is a negative thing. Okay, so it's just about tilting what we're already doing to make sure equity is embedded. And just start places where we know that we've got problems or that there's an evidence base to tell us, that there are problems. So, for example, reducing missed appointments. We know that people in deprived communities miss so many more appointments than people in the most affluent communities. We know that it's often where they're dropping off the treatment pathways. That's where inequalities and waiting lists then start appearing. That's when we're losing these opportunities to engage with them with preventative work or all the other things that we need to engage them with. So starting in those places that makes sense, and we already know there's likely to be issues. Again, kind of waiting lists. We know that access is really difficult for these communities. You might have very specific needs within your CSUs or specific communities that have particular issues. Start there. It's a good place to start. So just to highlight a couple of quick things, we are going to be taking a bit more of a broad approach to kind of organisational workforce development in terms of health inequalities over the coming year or two. But at the moment, there are some key resources out there if you want to kind of do a little bit more in this area, skill yourself up, skill up your teams. There's a health inequalities in secondary care. It's just 1 hour module that's been devised by Fair Health that's available free to everyone to access. These things can be found on the intranet on the health inequalities page, okay? There's some links in the slides, and I'm sure these slides will go out to colleagues as well. But also there are some groups at the Trust that you can join. We have a Health Inequalities in Public Health group, which is open, Trust-wide, where we look at kind of different themes, different inequalities issues, try and equip ourselves, have these conversations about what do we do, where do we go next. And there's some quite specific inequalities groups in various departments, ED, cancer, children's, for example, who they're bringing together interested people to look at these areas. So there's plenty of ways to kind of get involved and get some additional support if you need them. So contact details again of myself and my colleague Charlotte Orton, who is a specialist kind of public health program manager at the Trust, who works at the Trust full time, there to support teams if you need it. So going to the table discussion, Really what we want you to start thinking about is what more could be done to embed considerations of health inequalities within the work of your CSU. I think a really important question to consider: what are your existing change programs? What things are you already hoping to achieve? And how might you tilt those to make sure that they are narrowing the gap rather than kind of widening inequality? Which kind of patient groups, for example, might you need to give extra consideration to? Consider differences in access and experiences that you're already aware of, okay? That's a good starting point. What more could you be doing? So we'll leave these conversations and questions. Again, I think you've got about 20 minutes for this discussion. And similarly to last time, I think Phil will take some feedback at the end. So hand back over to you, Phil.
Thanks very much, Anna. I think really powerful messages for us all to be thinking about. Okay. You weren't expecting that, were you? Yeah, some really important messages, I think, for us all to be thinking about. Traditionally, not what hospitals do. It's that perception that what we do is treat everyone when they turn up, and of course we do that, but some real thought that we need to give into. Now, we've had some good discussions. As always, we're slightly behind time. Suggestion is that you get yourselves a coffee and maybe come back to your tables, have that conversation over the next sort of probably 20-25 minutes. We might try and get to the end of this session by 11:30. So if we could move into the kind of break and table discussion at the same time. Great, thank you. Okay, folks, can we come back together? I've got no phones in my pocket, so I'm not taking any responsibility for that feedback. Thank you. Good, so thanks for that, and appreciate you grabbed a coffee and had the conversations. But I think a really important area of our work that we think about, but actually perhaps need to be more purposeful about. So again, let's. I hope that's been a good discussion about what you think you can do in your CSU or corporate area to think about this really important agenda. We'll just do the same thing for a few minutes. If anyone's got any really important comments they want to feedback at this stage, but again, please use the Slido to capture feedback, and we'll get all of that collated and sent back round everybody. But has anyone got anything they just want to put into the room now, or thoughts? Rachel, lovely, thank you.
Thank you. So this is Chapel Allerton CSU table. So we had quite a lively discussion about this actually, because I think there's quite a lot of work that we can put in. But one of the things we got a bit excited about is DNAs. So we have quite relatively high DNA rates across the business units in our CSU, and obviously that results in quite a lot of waste. But we were just thinking about ways that we communicate to patients. Do we give them enough time? Are patients able to use a phone? Can they read a letter? And we felt we needed to look into the reasons why our patients are not attending, looking at the demographics and getting some patient feedback.
Great, thanks Rachel. I was really struck by the point Anna made in her presentation about looking at some of these questions through a poverty lens, and I think that's a really good example of something where do we understand why what's driving those challenges. So no, thank you for that, really important. Anybody else want to come in? Yeah, thank you.
Hi, Ashley Cowton, General Manager in Outpatient CSU. So we'd like to introduce a complex access team at the front door of the Trust for our patients. We know our GP practices have got rich information on System 1 regarding patient needs. We feel our challenge is how do we integrate this with a system in LTHT or pull it across onto the referral. This would enable us to flag their needs, have the right conversation at the right time, and respond to their requirements to support attendance, reduce DNAs, and provide more of a personalised wraparound approach, which would narrow the gap.
Fantastic, Ashley. Fantastic, Ashley. Thank you very much. I'm seeing nods. £2 million on stamps. 1.2. Okay. Fantastic. Thank you, and thanks Ashley and team, because those practical suggestions, I think, is how we get from all recognising the challenge to what are we individually and collectively going to do about it. I can see a lot of nods around the room from that. Brilliant. Thank you, Ashley. Yeah, thank you, James.
James Beck, Clinical Director for Adult Critical Care. Not so much a solution, but just some stark data that we've just pulled for intensive care. If you look at the percentage patients admitted to intensive care units around the UK, the least deprived quintile to the most, the range is 17% up to 22% of patients. On the St James's site, the least deprived patients represent 12% and the most deprived represent 42%. So we're seeing massive differences in health inequality there.
Gosh, thanks, James. So it's important just to, again, see the stark reality translated from a high-level national or local data set into what we're actually seeing in a hospital that serves, actually, as we know, a city with some significant deprivation. So thank you for that. Can't see anyone else desperately wanted to come in. So again, I hope that was useful. Collate that information. We need to be thinking very hard. It's not it's not a particular insight to suggest that there'll be something in the 10-year plan around the challenge we've got around health equity. So as an organisation, it's something we're really going to have to kind of start focusing on even more than we do at the moment. So thank you very much for that. And I think it moves us very nicely into the last part of the morning, which is the importance of working with our partners in the city, in the ICB, in the region. I'm delighted that Brodie Clark and Selena Douglas, Chair and Chief Exec of the Community Trust, are joining us for this session. And then at lunchtime, as a board, we're meeting with the board of the Community Trust, because it's really important that we also think, as all of you do as well, how do we work with our colleagues in one healthcare system, which is being carved up into a certain set of rules. But actually, again, if you're a citizen accessing health, you don't know about all the complexities of different organisations, and it's really important that we, as we are already doing, but continue to think, how do we work effectively, collaboratively, fairly, accountably, so our Leeds Way values around our relationships with our partners. So very grateful for Esther, who works in my team, who's going to give us a bit of a summary of all the partnerships that we are now kind of involved in, and I think that's hopefully a preface into another table discussion shortly. Thanks, Esther.
Hi everybody, and for those of you who I haven't met, my name's Esther Innislim-Bachia. I joined the Trust in June on a secondment, so I'll be here for a year, and I've come from one of our partners from the Department of Health. So, partnerships. Oh, wrong way, that was a good start. So the importance of partnerships, I'm going to just briefly touch on. I think we are all aware of the challenges that have been discussed today, the things that Linda mentioned at the start. Some of those things are within our control, but a lot of them aren't. They are part of problems across the wider system. And so we can work on efficiencies and problem solving within the hospital, but unless we work in partnership across the system, we're never going to resolve some of these things or make headway. So why are we doing it? It's a really important part of our strategic priorities. It's a bit difficult to see on the triangle on a screen this big, but that first layer underneath strategic priorities, that is one of our strategic priorities around integrated partnerships and services. Next one. So who are our partners? This is not an exhaustive list because there are so many different organisations working across the health and care landscape that we need to interact with. So there are the other NHS trusts that we work closely with. There is our primary care colleagues who we've talked about already today, where we're getting an increase of referrals. As an acute trust, we work really closely with the other big hospitals across West Yorkshire through Wyatt. And then there's the other partners in the city and place. So we've got Leeds University, who we work really closely with, the council, the public health agenda, the combined authority. It's a really busy landscape. And I'll be really honest, since I joined in June, half of the battle of my job has been learning all the acronyms for these different partnerships and trying to understand how they all interconnect. I think the main thing here is there is lots of different players, and we need to be working in a really collaborative way to be able to make changes. So because we are part of these partnerships and because we are trying to work really collaboratively with our partners, I just wanted to highlight that we have our trust objectives, but we are also accountable and working towards shared priorities and objectives. For example, the Healthy Leeds Plan and the 5 shared priorities that have been set out for the city. So whilst we are working internally and as an organisation to meet our own priorities, we need to have a view to those other priorities across the system and the region. And that is something that I think is particularly challenging for our organisation because of the size of us, because of the nature of the work we do. We have that responsibility both to place and region. I won't bore everybody with the never-ending governance structures that underpin some of these partnership arrangements, but to give people a little bit of an idea, in the city, about how are these decisions made, how do we practically work with these partners. So you have a kind of statutory function. There are some groups like the Health and Wellbeing Board or scrutiny boards that are statutory functions that sit with the council or the ICB that we are part of as well. They are the decision-making groups. We also then have PLT, Partner Leadership Team, which is a high-level kind of strategic oversight group made up of CEOs, leaders, so Phil sits on there, that try and look overarching of the work that we do in the city and give a bit of strategic direction. But underneath that, and this is where hopefully some of you may already be getting involved, or myself and Dan Gilpin as the Medical Director for Partnerships Integration might be coming and tapping you on the shoulder to say, could you get a little bit more involved in these? We have population and care delivery boards. So these are the groups that are looking at themes in the city, themes of work, and they are trying to drive some of that agenda around the priorities that we face. So, as I said, some of you might already be involved, but as you're having the discussions today, think about, is there maybe a role for yourselves or somebody in the CSU to be more involved in those groups? So we already do a lot of partnership work. We do some really great stuff, and things have already been mentioned today. Again, there's no way I could provide an exhaustive list. These are just the ones that had good pictures or logos. But it's to really highlight that actually when we come together with our partners, when we deliver things collaboratively, we have better outcomes for our patients. So Home First is a fantastic example. A lot of you will be aware of that. But it's impacted over 3,000 residents, and it's avoided almost 1,000 hospital admissions. That programme of work is now kind of looking at how it dissolves from being a transformation programme into the business as usual across organisations. But part of its success was that all partners really rallied behind it. There was resources given, and it was a shared priority across the city. We've got other fantastic kind of national partnerships. So the National Pathology Imaging Collaborative has really made a difference for patients by improving the systems and digitising services. And then the picture of somebody being jabbed is the rollout of the COVID vaccine as well was a fantastic example of how partners in place came together really quickly to deliver things. So why is partnership so important at the minute? We are already doing it, but we need to be scaling up our efforts and thinking more strategically across the organisation about how we work with our partners. A lot of the conversation earlier on today about the challenges that we face and the national narrative is about left shift. Left shift, care moving to the community, one of the 3 priorities from government, hospital to community, they're all a similar thing. The idea being that care is not best given in hospitals, and that provision needs to be moving out into primary community care in a place that is more appropriate for patients closer to home. The reality is that's really difficult, and there are a lot of challenges involved. And I think what's really important is that people on the front line, clinical teams, are involved in those conversations. We know that this is coming nationally. The 10-year plan will have things about this. But separate to the 10-year plan, we know that there is a real push around a neighbourhoods agenda, so having kind of a neighbourhood model, hyper-local care, and that will involve specialist care from secondary care services and hospitals like ours. So we need to be involved in those conversations. We need to help shape that direction of travel, because you guys know best how that will work, what the realities of taking that policy vision to what it practically means for our patients. So that was a very kind of high-level summary, because I think the really important thing is that there is some time for you to have a discussion about this. There is lots of things already going on, and I know that some of you will be working closely with Dr. Dan Gilpin, looking at some of your pathways and how you can work better with partners across the city. But I think what would be really helpful for you all to consider as part of the next table discussion is, what are the barriers? What are the things that are really challenging? Is it about capacity? Is it about resources? Is it about the funding? You know, those things that are practically making it difficult to change the way we deliver things, please be honest about those. Make sure that we're aware of those so we can feed those into conversations that are happening. So I think we've got 20 minutes again, and please do use the slider. I can see that people are using it, and that's really helpful because it means we can take away your thoughts and feedback and work on it after this. So, yep.
Great. If we could come back together maybe around just after 12:10, that would be great. Thank you. Hi folks, great to see the really rich discussions that's going on. Can I perhaps just bring us back together again for a few minutes just to get a sense of what people have been talking around, what you're building on, the work that I know all of you are doing around kind of partnerships, and I think to the questions up there, kind of where the barriers and challenges are as well as where the opportunities are. So again, please use the Slido, but has anybody got anything they really want to feed back into the room right now? Just waiting for our lunch. Oh, Chris. Sorry, Chris, couldn't see your hand up.
Thank you. I just wanted to reflect on some of the work we're doing across the city from a research and innovation perspective. Research often works in silos, in organisations and sometimes even in departments. And we've been doing quite a lot of work with Leeds Community Health in particular to look at actually how we join up our research pathways more and how we enable some of our research teams and researchers in the trust to identify populations in the community setting that would actually benefit from research that we're not able to identify from within the hospital at the moment. So back in January we did a workshop with a number of stakeholders across the city from GP, Confed, Community Health, Mental Health Trust and social care to look at what the barriers would be and what the barriers are to doing this. And they came out as sort of being information governance, access to facilities and sort of HR portability working across organisations. So over the last 9 months, we've been putting in place some solutions to that. So we're now testing some processes with our diabetes research team and respiratory research teams, where we're putting in place portability agreements that would be used normally for clinical care. We've customised them for research. So working as part of the One Leeds workforce and using that model. We've got a potential pathway and arrangements with information governance colleagues across the 3 organisations, how we can access the records in an appropriate way to do the screening. And we're just testing those models now, and if they start working for the first couple of projects we're looking at, we're starting to look at actually how we work more collaboratively the system, how do we take that into the GP world, how do we take that into the mental health world as well, but then come together to reduce some of the duplication that happens across research in the city to creating that sort of One Leeds research approach.
Brilliant, thanks Chris. I think that's a really great example, and I love the sort of problem and then solutions focus around that, because like all of these, it's about thinking what can we actually do to move the agenda forward. And Brodie, I can see you wanted to come in. Sorry, just back over here. We'll just take that comment because I guess you want to come in on that, Brodie.
Well, I think it reflects quite a lot on the question of the how, not the whether. And I think we had a great conversation at the table about what works, what can go forward, what should go forward, what it should look like as we take it into new areas and a new direction to a large extent. But I think the challenges around the how, the challenges around the cultures, the challenges around the divisions, the money, and how things are broken up in different ways. And I think that really does merit the consideration that we need to give carefully and thoughtfully, but not over a 20-year period. It's got to happen soon. Thanks, Brodie.
Yeah, I think that's right. I'm sure everybody in this room will put the person at the heart of what we're trying to achieve, and I think that's the driver of the how, isn't it? Is we keep person central and break the barriers down to allow them to have that.
Hello.
Hi.
Shubha Chipeta, lead clinician for gynecology. We took the opportunity of very long waiting lists within our gynecology department, with women waiting well over a year for a first gynae appointment. And the fact that we've now got a women's health strategy and the need to build women's hubs to try and kill 2 birds with 1 stone. We've set up a women's hub in the BHR PCN, which is one of the most deprived areas, high DNA rates, extremely long waiting times, women who have issues with access to healthcare. and set up an outreach clinic. We deliver way more primary care gynecology through that service. We've trained up 2 GPs. We're going to carry on a community gynecology service. We've got patient ambassadors that are enabling women to access healthcare for basic conditions such as menstrual disorders, polycystic ovaries, menopause issues, and PMDD. And all of that to say that using the ICB, primary care colleagues and LTHT together, we've really helped both reduce waiting list times for those populations and also hopefully deliver care closer to home for those women. So we're very, very proud of that initiative, and we're hoping that we'll develop a hub and spoke model for gynecology services in Leeds.
Fantastic, thank you, Shilpa. I think hugely proud of that work, and I think it's a great example. I mentioned this morning about how the NHS isn't very good at scale up and spread, and actually we're a big, complex, diverse organisation. One of the things I think we have to get better about is how do we look at that example for, across other services that are experiencing the same sorts of pressures. So really great. So go and talk to Shilpa afterwards to know how you set that sort of service up. But seriously, I think, we've got to learn from each other. We've got to, and that's why these events are so good, because actually you get a chance to hear things that you might not otherwise be aware of. We've got to keep going with the messages we can get out so that you can all find out what the great work that everybody's doing, but what would be better if we could come together and share all of our great practice. Okay, any last comments, any last question or reflection? We're good at seeing hands up. No? Okay, great. So I think we're coming towards the end of the morning. I think our final... What's this to do? Turn my mic off.
Okay, that's it. Had the thumbs up. You would have been really in the doghouse up there if that hadn't worked. There you go. Right, you've got the joy of me wandering around here now. I personally think this has been a kind of fantastic, again, way of actually not just working together, but actually also getting to know one another. Because the great thing for we sitting on these tables down here is that we're not just working colleagues, we're friends, and we can be open and honest with each other. And that's the bit that I just want to go to now, because we don't have a them and us in our organisation. We are one team. That's when we come out to your services, talk to you, get involved with you, get to know your first names as well as your kind of big titles that a lot of you have got. What can we do at the kind of board? We've got all the non-execs, the execs are with us. What can we do? Is there anything that you want to message up now that can help unlock, uncover, develop, work with you on more than we do? Is there a line that says, that's great, but... It's usually money, so where Jenny Earhart is, but she's hiding. But they're amongst you now, the executive. And I want you to feel free to ask anybody anything. We've got estates facilities, we've got finance, we've got HR, we've got development, you name it. Everybody in this room is here. Come on, somebody say, well, if you did, or can you message up? I mean, I'm 3 days in London next week. I'm happy to take some very tough messages up, regularly do. So tell me, is there anything more we can do to help you? Who's brave? Oh, love it. Love it, love it, love it. Go. I haven't the mic, so I'll just...
Thank you.
Say who you are, because it helps.
Rachel Irwin from lead clinician from dermatology at Chapel Allerton. So we were just chatting about one of the biggest challenges, and I think it's getting worse and worse, is the relationship between primary and secondary care. The partners in the middle who seem to have more power to say, no, we can't do something, or yes, we can something, and then the GPs and us at either end. And what that means in dermatology, rheumatology, is we're seeing more and more patients that could be better for the patient, for everyone involved, be managed better in the community, but the community services are not necessarily fit for purpose. And I don't know if that's across other specialties. And we're seeing more and more pushback from GPs, very unhappy, because we're asking them to do things for our patients because it's things that we don't need to do in secondary care. So I guess it's just how can we better improve the whole pathway for patients? How can we engage better with GPs? It feels like there's becoming increasing distance between us and general practice, in our specialties anyway. And if there can be some help from on high to help with that, I think that would be really great for patients.
So which executive is going to now be on the spot, Phil, to say what more can we do? This is a clear message. A, with the community are in the room. Magnus, I love a volunteer. It's far better.
I was going to pick someone, but that's
fine. You were going to pick someone.
Yeah. I think you were going to pick me anyway, Phil.
Yeah, go.
Rachel, you're absolutely right, and that's part of the conversation we just had on this table, so I'm on cardiorespiratory. I think the forum to have primary and secondary care and that interface and being able to discuss it properly is absolutely right and proper, and I think we're in a structural-based health and care system, and we need to knock the walls down. Patients don't care where they are within that. And the sovereign organisational boundaries that we've worked with at the moment don't need to be there anymore. It sort of fits with what Ara Darzi said, from hospital to community. Dan sits on the LMC with Rich Baker, they help there. I think there's probably something more than that, and I think it's probably the emotional connection that used to be there between GPs and consultants that we've lost over time that we need to think about how we build back up again. So I'll consider that and take it away to my senior team. I haven't got an answer for you right now.
Well, I'm listening to you.
I didn't realise you were just there.
Yeah.
Sort of slightly alarming that you're literally there.
I'm still here.
Yeah.
And I think, turning to the executive and Joe's board sec, that we'll have this as a point of discussion, not just amongst the execs, which you'll do anyway, but we'll have a look at it at board level and say, what more can we do with those partnerships, and how do we do it together? Interestingly, sorry to interrupt you, but I'm prone to that. Yeah. Still lurking around you. Is that just yesterday, twice actually in the last few days, I've had conversations, quite interesting, very interesting conversation with the local authority, because social care we forget at our peril, quite frankly, because this is creating an awful lot of issues. I'm talking about this nationally as well. And it is becoming, it annoys me actually, because regardless of what administration we've had to deal with in the last 20, 30 years, the data was making it quite clear that given excellent number of years, we've got an ageing population who have got a lot of comorbidities, and as we all know, and look where we are. And there's been absolutely zero planning for that, nothing. And so we're now in the crisis point where we're all trying to sort it out. Now, the thing is, recognising there's a problem is a good start to focus the minds. And so that is the messaging I want to say to you going up, that we are looking at. And we have a golden opportunity coming out of the conversations that I had yesterday and on Monday with them, that there is a willingness to actually get really serious about this. For instance, the Health and Wellbeing Board, and we're unique in Leeds, which is organised, administrated out of the local authority. I co-chair with the council lead on that. And it's the only one in the country that we co-chair. So we had our meeting yesterday. And what we're going to focus on, it started off a few years ago as a bit of a love-in. and their agenda didn't fit my kind of, can we just start delivering, not talking about how clever or good we think we are when actually we're not that clever or good then. So we're going back, probably been doing it, I don't know, Joe, 4 years-ish? Yeah, about that. Yesterday, absolutely all joined up on we're going to have the next Health and Wellbeing Board, which has everybody at it. Brodie, you're there, Selina. So mental health, community trust, ourselves, the third sector, the charity sector, social care, tick. We're all in that together. We're going to focus on elderly care. And it isn't about this, let's talk about things, how difficult it is. And I made that clear yesterday, and anybody that knows me, certainly my team, so when are we going to start delivering then? So what we need to come out of is the discussion about primary care, by the way, sorry, they're in the room as well. But they're a bit disjointed at the moment, you know, since the CCG changes and all, they've lost their way a little bit. But we've got to remember, of course, these are private sector organisations that you have no control over. So if they decide to do or not do, that's down to them. I don't think the general population actually understand that. So they are quite we're lucky we have some really good ones in Leeds that do want to engage with us, but not everybody does. And that's a big issue. But we are all in the same room. I don't know whether it gives you any comfort that we are pushing it to get us in the same room to actually start saying, these are communities' challenges, these are our challenges. What's really interesting that brings us all together is when you've got financial issues. It focuses the mind unbelievably that we all need to get out of our own individual mess. Magnus.
So Linda, just coming back on that, and as you were talking, I was thinking, there's maybe another way of thinking about it as per capita cost per case, per care, and clinical care pathways. And if there's many handoffs between GPs, secondary care and intermediaries, they're non-value add for patients.
Yeah.
So we can improve patient experience and decrease that per capita cost, which is, I'm almost getting to a triple aim for the whole patient group. And if there's clinical care pathways where we can do that, then there is an advantage. But I suspect the thing that makes that change is the emotional connection between individuals in that system, which you've just described we haven't got in the right place at the moment.
Yeah. Well, we'll make a start. We have made lots of change in that period. Some of it a bit subliminal, some under the scene. But you know, people have to learn to trust one another, to work with one another first. And I think we're at that stage in Leeds now. And then when adversity comes, which is money, then it's kind of, well, so how can we work better together? And you know, sometimes we start with people, back to what I said earlier, the patient. If we start with that, the money will follow if we're all smart together. But right, great, well, super. Here we go, over here.
Hi, Amina from Adult Therapies. For us, it's around speed of PPM plus developments and access to clinical pathways across the system, such as System 1, and how we share data and other things to help that clinical pathway across the system.
Great one, love it. Paul, where are you? There you go, please.
So how rude do you want me to be? You know, we get the IT that we fund. We only spend 1.2% of our revenues on the digital team. I was on a phone call with guys in St Thomas yesterday. They spend 4%. So the speed is the speed. The decisions about which forms get done in what order is not the digital team. We have a prioritisation process. We engage the clinical leaders, the nurses, doctors, some from the ops team because some of that's important. So the decisions about what order we do things in is not a digital decision. So those priorities sit with you, and so kind of make your case for how you want those things to be positioned in a priority, and then we'll do the best delivering to the priorities that you set within the resources that we've got available. I would love to do more. I would love to do a lot more, but we're all constrained, as you're constrained as well by budgets and resources. In terms of engaging across the city with more engagement for systems there. I do think that is something we need to look at. We've been slightly constrained by some of the structural things with what was the CCG becoming Leeds Place. The IT's kind of merged in with the council as well. So I'm actually meeting with Tim Riley and Jason Brook, who are two of the leaders in that space in Leeds Place, in the next week to just work out how we can start at least having some more discussions about how we can work better from a systems point of view across the city, and hopefully we'll see some progress in that space.
And that will come back to board, I assure you. That filters up as to...
Can I just add a comment in
please,
there, Linda?
Please.
Which is, because Paul and I have discussed this many times, if we had, like a lot of comparable organisations, spent hundreds of millions of pounds on a commercial EPR, you wouldn't have been able to ask us that question. So for all the faults we might think we have around PPM Plus, if we were on Cerner or Epic, we'd have opened a box, plugged it in. I summarise quite a lot of work in that, and then that would be that. And the option of what we could prioritise based on clinical feedback would simply not be there at all. So it's really important that we recognise the real strengths we've got of an in-house EPR and our ability to shape it to what we need, and our ability actually to think about the rest of the system connecting up in a way that we simply wouldn't be able to do if we bought a commercial system.
I'm looking at the clock, and I know people have got to go at 1:30. I mean, we could go on talking forever. I could talk for England, as you probably gathered. But, I mean, is there anybody thinking, burning, I've got to say something, I've got to say something, on anything, before we go? Oh, go.
So I think this is, so my name's Damien Tolan. I'm about to become the Clinical Director for Radiology, and I'm also the lead for the colorectal MDT. I think something that really stifles us clinically is actually getting meaningful data back from the NHS to actually give us meaningful clinical dashboards. So huge volumes of data leave our organisation and then take weeks, months and years to come back. And we've got very little control or influence of how that comes back to us, and often it's given to us in ways that aren't really very useful for sort of performance improvement. And I think one of the things that we're all sort of noticing is that, you know, motivating our teams is very difficult, but it's particularly difficult if they don't have data that actually means something to them to make them feel that they're going to do something with that to improve. And I think dynamising that process is essential if we're going to motivate highly trained people to actually do a job much better. And I don't see that there's really much of an appetite or desire to accelerate that feedback loop. And I think that's critical for the NHS. And I see this in my own area of colorectal sort of cancer stuff, but I'm sure it applies to almost everything.
Yeah.
But I think that's something that outside Leeds has got to sort out to allow us to really, really improve in the way that we want to.
Yeah. I was at something, it's a few weeks ago now, and a larger, not as big as this room, but there were similar comments coming from all over the place. They recognise it a problem. We send data, tons of it, out. My comment has often been, many times, what do you do with it when you've got it? Because even when we have to send data to them, it's never in the same format. Probably there's, well, within health, it's going somewhere within health, but to different bodies in different formats. And none of it's ever made sense. And it was quite a relief, actually, in that room to hear other people saying the same thing. The only thing that I would say is that, we can get into the actual, I can turn to Paul and notice him nodding, but I think it's probably bigger than that, because we've got an administration who are, as you heard earlier, creating a 10-year plan. Within it, there's technologies that they want to kind of invest in. They're going to have to put the money where the mouth is there. There is dialogue of change going on. But none of this is quick fix, quite clearly. I'd like you to feed that to this website that they've got, that they want this feed for the 10-year plan. Because the more that we send up things like that, the more that they will see this as a priority, as against what can we do, let's be fair, what can we do in the next 3 years, 5 years, if they get another 5 years on top of that, well, we'll see. But the more that we tell them this is bust and needs fixing, and there was a volume of voice where I came from, so I think there's an opportunity there. I can't give you an answer, I'm sure Phil's now telling me to shut up, but basically, okay. Right, I've done.
Thank you, Linda. It's spared me the career-limiting conversation I was about to have to have with you, so thank you for that.
So look, folks, we've gone slightly over time, but I think it's been absolutely fantastic discussion. I really hope you've enjoyed it as much as I certainly have, because hearing the energy, the enthusiasm, the commitment. Look, we've got some big challenges, folks, but we know there's an organisation that can deliver against those challenges, and that's Leeds Teaching Hospitals, and all of you in the leadership roles you're in, and all of the teams you work with. And let's just hold on to that story we heard from Claire, and let's just keep that at the heart of what we do in the organisation, because that's where our values come from. That's what gives people the reward they want when they come into work. So let's face the challenges we've got together, which we always do in the organisation. And I know full well that the people in this room and the 22,000 people in Leeds Teaching Hospitals will continue to deliver the best care we can for our patients. Thank you for coming. We'll summarise the Slido stuff. We'll get it all back to you. Let's keep going. Thank you.